Quick overview of asparaginase. Asparaginase is a drug to fight acute lymphoblastic leukemia. Lymphocytes are the good cell in our body that keeps fighting the bad guys. But sometimes lymphocytes can go bad, become leukemia cells, leaving our children to be sick, tired, and fatigued. So one of the drugs to fight acute lymphoblastic leukemia is called asparaginase, and we are group number 14, Courtney Kimmons, Robin Kim, Ina Kim, Wendy Kollar, Carolyn Koshy.
So what is asparaginase? It is a drug to fight acute lymphoblastic leukemia. So asparaginase is called L-SPAR, and the class it falls under is anti-neoplastic chemotherapy agent. It is to treat acute lymphoblastic leukemia, also known as ALL, and non-Hodgkin's lymphoma. It's also given as IM or IV. So what is the mechanism of action? It's a cell cycle specific for G1 phase. Normal cells have the ability to synthesize asparagine, while cancer cells require asparagine. In leukemic cells, asparaginase hydrolyzes L-asparagine to ammonia and L-asparagic acid, which leads to asparagine depletion.
To emphasize a little more on asparaginase, normal cells are dependent on an amino acid called asparagine in order to survive. This goes for cancer cells as well. However, normal cells can synthesize asparagine themselves while the cancer cells cannot. The enzyme asparaginase breaks down asparagine in the body into aspartic acid and ammonia. This is okay for normal cells because they just continue to synthesize the asparagine as needed to keep surviving. But with cancer cells, breaking down the asparagine in them causes apoptosis. So taking the asparaginase will increase the breakdown of asparagine and cause the cancer cells to die off. One of the adverse effects is hypersensitivity. This can be caused due to a foreign protein producing an immunological effect. This can range from localized arrhythmia to systemic anaphylaxis. Another adverse effect is bleeding. Asparaginase decreases the synthesis of many plasma proteins such as fibrinogen, plasminogen, antithrombin 3, and proteins C and S due to the depletion of asparagine. This can lead to thrombotic effects such as strokes and seizures. Another adverse effect is CNS effects, such as sleepiness, agitation, confusion, disorientation. This is due to increased levels of the two chemicals ammonia and aspartic acid. Hepatotoxicity is another adverse effect. The asparaginase is directly toxic to the liver cells, causing inhibition of protein synthesis and also the exporting of lipoproteins and lipids. This in return causes fatty liver, which leads to hepatic dysfunction. Mechanism isn't fully known, but it is thought that the asparaginase causes depletion of arginine. This can be reversible if asparaginase is discontinued among signs and symptoms such as fatigue, dark urine, and jaundice. Although rare, acute pancreatitis and hyperglycemia are two other adverse effects. The mechanism of pancreatitis is not clear. Pancreatitis is assumed to cause secondary hyperglycemia. Symptoms of this include sudden severe upper abdominal pain, which can also be felt in the back of the patient. Nausea, vomiting, fever, chills, and diarrhea are a few other symptoms of the acute pancreatitis. While taking asparaginase, or if you're going to start asparaginase, you want to look out for drug interactions. One of these interactions are cytarabine, which brand name is Deplacent. Taking asparaginase with this drug will lessen the effects of cytarabine due to suppression of asparagine levels. To reduce this interaction, asparaginase should be taken after cytarabine. Another drug interaction is methotrexate, which the brand name is Trexol. Taking asparaginase with this drug will also lessen the effects of methotrexate due to suppression of asparagine levels. To reduce this interaction, asparaginase should also be taken after methotrexate. The last drug interaction is vincristine, which the brand name is Oncovin. Taking these two drugs together will increase vincristine neurotoxicity. The mechanism of this, however, is unknown.
Asparaginase comes in various formulations, for example, E. coli and Erwinia. Both are given as intramuscular and intravenous injections, and both are refrigerated at 2 to 8 degrees Celsius. In E. coli formulations, the reconstituted solution should be used immediately after preparation. However, it is stable for 3 hours at room temperature or 72 hours refrigerated, whereas Erwinia formulations are to be used within 15 minutes of reconstitution. Also, it is important that in the Erwinia formulations, do not freeze or refrigerate the reconstituted solution, and it should be discarded if not administered within 4 hours. It should also be protected from light. Now let's discuss the pharmacokinetics and dynamics of E. coli asparaginase. The distribution of IV is slightly higher than plasma volume with less than 1% CSF penetration. Its metabolism is systemically degraded and only trace amounts of the dose appear in the urine. Its peak time in IM administration is 14 to 24 hours, and its elimination half-life is 34 to 49 hours for IM and 8 to 30 hours for IV. Erwinia asparaginase has an elimination half-life of about 16 hours for IM and 7.5 hours for IV. Here is a table of pharmacokinetic characteristics of 3 asparaginase formulations. As you can see, PEG asparaginase has the longest half-life depletion and peak activity, followed by E. coli and then Erwinia formulations.
An important mechanism of drug resistance toward asparaginase include the function of an enzyme being glutamate-dependent asparagine synthetase, also known as ASNS, in tumor cells. This enzyme functions to synthesize the L-asparagine in normal cells, which is required for building proteins. An article by Nigel Richards and Michael Kilberg focused on both the drug resistance to childhood acute lymphoblastic leukemia, or ALL, and mechanism of action of ASNS. According to the article, asparaginase resistance is obtained when L-asparaginase sensitive MOLT4 cells, which are T cells derived from a leukemic cell line that was isolated from a patient with acute lymphoblastic leukemia. This presents with an upregulation of ASNS. The increased exposure to the asparagine synthetase caused the MOLT4 cells to obtain the resistant characteristic. Now this means patient with all or acute lymphoblastic leukemia have an increased number of receptors on the asparagine synthetase, allowing MOLT4 cells to be more sensitive to asparagine. This process permits the cancer cells to have easy access to asparagine to satisfy its demand for cell growth, thereby increasing the drug resistance against L-asparaginase.
Now, with all the information we learned from asparaginase, we can continue to learn other medications that could help us to fight against cancer for our patients.